A very good evening to all of you.
ठीक है जी, ठीक है, thank you.
Now with the running of this month, we are going to organize our 5th meeting of case-based discussions. And for this, luckily, all the leaders and good audiences there along with the panelists and speakers. And before we move for the scientific program, I will request Dr. K K Pareek sir to say a few words to boost our morale of all the speakers and panelists.
Thank you, sir. Thank you so much. It's really a great pleasure in welcoming all of you to this 5th case-based discussion on the platform of RSSDI Rajasthan chapter. I would also like to extend a warm welcome to our President API and Chairman Rajasthan RSSDI, Dr. Girish Mathur, who is a dynamic leader, Dr. Prakash Keswani, the Project Director for Case-Based Discussion, who has initiated this very good series of case-based discussion on different subjects of diabetes. I also extend a warm welcome to Dr. Anil Samaria, who will initiate the case discussion. Dr. Punit Rijhwani, Senior Professor of Medicine and HOD, Mahatma Gandhi Medical College, Dr. Surender Kumar, Dr. Sanjay Saran, Associate Professor of Endocrinology, and Dr. Surender, Professor, Senior Professor of Medicine. They are panelists for today's discussion. So, without wasting much time, I'll request Dr. Prakash Keswani for the further proceedings.
Thank you, sir. Thank you. Thanks a lot for your kind words. Now we'll request Dr. Girish Mathur sir to say a few words before we move for the scientific program.
Good evening, friends. It's my immense pleasure to welcome you all on behalf of RSDI Rajasthan chapter on this 5th session of case-based discussion in diabetes. At the outset, I extend my very special thanks to our mentor and guide, Dr. K K Pareek sir, for his valuable presence and for his constant support, help, blessings, and guidance. We are fortunate to get his blessings on all our scientific endeavors. My special thanks to Project Director of this program, Dr. Prakash Keswani, for all his sincere efforts. It is entirely to his credit that this program is running so successfully and smoothly. We are in the 5th session of this program today. My thanks are due to Dr. G D Ramchandani, the Dynamic Secretary of RSDI Rajasthan chapter. I welcome today's speaker, Dr. Anil Samaria, Professor of Medicine, HOD Medical College, Ajmer, and the panelist, Dr. Punit Rijhwani, Head of Department Medicine, Mahatma Gandhi Medical College, Jaipur, Dr. Sanjay Saran, Professor Endocrinology, SMS Medical College, Jaipur, and Dr. Surender Kumar, Professor Medicine and Additional Principal, SP Medical College, Bikaner. I also note the valuable presence of Dr. Shailesh Lodha, Dr. Pradyuman Sharma, Dr. SS Daria, Dr. Gwalani, and all senior friends. I think with the valuable presence of our distinguished faculties, Dr. Anil Samaria, Dr. Rijhwani, Dr. Surendra, and Dr. Saran, we will have a very interesting and enlightened discussion on a case-based discussion. Thank you so much, and welcome you again, every participant.
Thank you, sir. Thank you, Girish Mathur sir, for your kind words. And every time we try to get a case which always helps in diagnosis and managing various situations of the diabetes. Today, again, we'll start with an interesting case, and Dr. Anil Samaria will be giving his talk on about the case as well as the topic of this today's meeting. And without wasting much of the time, I request Dr. Anil to please start your speech.
Good evening.
Good evening.
So thank you very much, Dr. Prakash Keswani sir. बहुत बहुत धन्यवाद. Thank you, sir, for giving me opportunity to speak on the hypoglycemia unawareness. Good evening, all. Good evening, respected Dr. K K Pareek sir, our patron and mentor and guide. Dr. Girish Mathur sir, Chairman RSSDI Rajasthan Chapter and President API India. Dr. Prakash Keswani sir, Project Director sir. Dr. G D Ramchandani sir, Secretary RSSDI Rajasthan Chapter. All my respected seniors, dear friends and colleagues. As we know, the hypoglycemia is a common complication in diabetic patients. We seen in day-to-day practice in emergency rooms, most of the patients are coming with the hypoglycemia. Hypoglycemia, especially seen in the patient with type 1 diabetes, are more commonly seen. Type 2 diabetic patients also presented with hypoglycemic episodes with a presentation of hypoglycemic symptoms that are classified into two groups, autonomic and neuroglycopenic symptoms. If person develops the neuroglycopenic symptoms before the appearance of the hypoglycemic autonomic symptoms, the patient may develop unconsciousness and present in the casualty. These kind of presentation can be seen in hypoglycemic unawareness. That means the loss of warning signs and symptom of hypoglycemia. There is a decreased counter-regulatory hormone response to hypoglycemia leads to hypoglycemia, or there is a failure to treat hypoglycemia by the patient or attendant. This all causes a hypoglycemia unawareness. Here we are today present a case report of this patient is admitted in the Saturday in the emergency room. A 35-year-old female account officer in the veterinary department. She was a known case of type 1 diabetes mellitus. She was on insulin therapy. Her weight was 43.3 kilogram. BMI was 21.5 kilogram per meter square. She was admitted to hospital emergency room in the unconscious state and not responding to sensory and deep painful stimulation. According to history given by her husband, she was played badminton in the last night and the episode happened at 3 a.m. while she was sleeping in her room. Patient brought to the hospital by her husband in the emergency room. On examination, the vital sign of the patient upon arrival, the blood pressure was 130 by 80 millimeter Hg. The pulse rate was 114 beats per minute. Respiratory rate 18 beats per respiratory rate 18 per minute. Oxygen saturation was normal 99%. Temperature 36.8 degrees centigrade. But the blood glucose was 38 milligram per deciliter by glucometer. Immediately she was given cannulated and giving the IV bolus of 25% of dextrose through endovenously instantly. And after that, the patient's level of consciousness improved. She still had focal neurological symptoms, including the left hemiparesis and slurring of speech. He was responsive to pain and verbal command after 15 minutes of the treatment. After 2 hours, all neurological symptoms had disappeared that satisfied the Whipple's triad of hypoglycemia. All lab investigations were sent, including liver function test, renal function test, CBC, urine routine microscopy, thyroid function test, serum electrolytes, hemoglobin A1C, serum amyloid and lipase. All tests were normal except HbA1c is 16.2%. The insulin level was high and C-peptide level was low. That suggestive of this exogenous insulin was given, or there is no insulin production in the body. The CT scan was done because there was a focal neurological deficit in the initial time that was normal, and she mentioned having the type 1 diabetes since age of 16 years and was on insulin therapy. Insulin Regular was received 10 units 3 times before meals and insulin glargine 20 units at bedtime. She had history of hypoglycemia unawareness for previous 1 year with frequent 4 to 5 episodes of severe hypoglycemia in the last month and may had necessitated the assistance of others. Most of the episode happened at night time. For that, she was regularly admitted in the casualty ward and discharged in the morning after giving the glucose therapy. The patient lifestyle had changed in last 6 months because before 6 months she had very bad diabetic control. HbA1c was high. For that, she had begun routine yoga, badminton, and exercise for the glycemic control. She gave the history of poor appetite due to discomfort in the application since last month. That was she is consuming the less amount of food as but the regular insulin and is consuming is continuous without consultant with any physician in the last 1 month. And patient was discharged after 2 days and patient has been explained and relatives are advised to avoid recurrent hypoglycemia. For that, they have advised to monitor frequent blood glucose level, especially in the night time, or go for endocrinology consultation with CGM monitoring. Shift from human insulin to analog insulin with reduced dose to keep the blood sugar higher than the target value to resensing the hypoglycemic episodes. Also advised to keep emergency glucose tablets, subcutaneous or intranasal glucose at the her disposal all the time. And patient is discharged in healthy, no complaint at the time of discharge. Now come to the description part. We know the hypoglycemia is a very common side effect of various diabetic medication, especially the insulin is very notorious in type 1 diabetes patient, also in type 2 diabetic patient. Sulfonylureas, non-sulfonylureas, secretagogues can also cause hypoglycemia. Glinides can cause hypoglycemia. These can cause life-threatening episodes. Sometimes so much significant morbidity can be present. The many routine activities can be affected, like the job performance, driving, sporting competition. These can be affected by the repeated hypoglycemic episode in a patient. Hypoglycemia is defined as glucose level of less than 70 milligram per deciliter that is associated with specific symptoms and physiological responses. The symptoms may occur at higher glucose level in some patients. The symptoms and physiological responses may be decreased due to repeated episode of hypoglycemia lead to hypoglycemic unawareness. According to ADA, there are different levels of hypoglycemia. In level 1, there is a mild hypoglycemia. Blood glucose is less than 70 milligram per deciliter, but 54 milligram or higher. Here is the critical threshold for the autonomic symptoms are there. In that level 2, there is a moderate hypoglycemia. Blood glucose is less than 54 milligram per deciliter. Here is the neuroglycopenic symptoms have appeared. And level 3 is a severe hypoglycemia. There is a altered mental and or physical functioning that necessitate the assistance of another person to recover. Here is a blood glucose is often below 40 milligram per deciliter. As in our case, the glucose level is 38 milligram per deciliter. The prevalence of hypoglycemia in type 1 diabetes is unknown. The severe hypoglycemia affect 35 to 42% of patients with type 1 diabetic patients. Between 90 to 130 episodes for every 100 patients have been experienced hypoglycemia. The etiology of the hypoglycemia is when we are talking about the medication, especially in diabetic patients, those are on the insulin therapy, sulfonylurea, non-sulfonylurea secretagogues, all can cause hypoglycemia in a patient when taking in the excess amount or some other causes. Alcohol is the next in the causes of hypoglycemia. because there is an inhibition of gluconeogenesis, also lead to hypoglycemia. Then for the reminder, PQRST. These drugs can cause hypoglycemia in other than diabetic patients, like the P for pentamidine, propoxyphene, quinine, quinidine, quinolone, especially gretifloxacin is a very notorious that was removed from the market now. Only the ophthalmic solution are available. Ramipril and other ACE inhibitors can cause hypoglycemia. Salicylates, thimethoprene and sulfamethoxazole also can cause hypoglycemia. Another causes of hypoglycemia are critical illness, especially end-stage hepatic failure, end-stage renal failure, cardiac failure can cause hypoglycemia. Severe sepsis can lead to hypoglycemia. During starvation can cause hypoglycemia. Some hormonal deficiency can cause hypoglycemia, especially cortisol, growth hormone, glucagon, epinephrine can cause hypoglycemia. The endogenous hyperinsulinism is another cause of hypoglycemia when patient is suffering from insulinoma or necidioblastosis. Non-insulinoma pancreatogenous hypoglycemia is another entity can cause hypoglycemia. Post-gastric bypass hypoglycemia is also common, especially in pediatric patients, pediatric surgical patients. When patient develop the antibody to insulin and insulin receptors, can lead to hypoglycemia. Non-islet cells tumor, especially lymphoma, leukemia, sarcoma, steatomas, can also cause hypoglycemia, but rarely. Accidental, malicious, and factitious hypoglycemia are the another entity can present in the medical emergencies. What increased risk of hypoglycemia? Patients with type 1 diabetic patients are more prone to develop as compared to type 2 diabetes. These are the most common in type 1 diabetic that presented with hypoglycemia. Patients with tight or near normal glycemic control are more prone to develop hypoglycemia. Approximately 25% of patients with type 1 diabetic have a major hypoglycemic event in his or her life. The risk factors for the hypoglycemia are insulin. Insulin secretagogue is the given in an excessive amount can lead to hypoglycemia. Insulin or insulin secretagogue given at the wrong time also can lead to hypoglycemia. Reduction in the carbohydrate intake when during fasting or some other causes that leads to reduced carbohydrate intake can lead to patient with a hypoglycemic episodes. Glucose utilization is increased during exercise. As in our patient, the patient is also taking the excess insulin, taking insulin at the wrong time, reduce the carbohydrate intake because of epigastric pain in our patient. She is doing regular exercise at badminton, playing badminton also leads to glucose utilization is increased in our patients. So there is a chances of hypoglycemia more in our patients. The insulin clearance is reduced in especially in the renal disease, but our patient is not suffering from any renal disease. How to diagnose hypoglycemia? Whipple trials fulfills the hypoglycemic diagnosis. In the Whipple trials, there is a signs and symptoms of neuroglycopenia or neuroautonomic symptoms that is present. Low plasma glucose level and rising plasma glucose level relieves the symptoms of all neuroglycopenic or autonomic functions when we giving the plasma glucose. All the traits, symptoms and sign consistent with hypoglycemia, a low plasma glucose level, raising plasma glucose level relieves the symptom. These are the Whipple traits that used for the diagnosis of hypoglycemia. Now, glucose homeostasis is the balance between insulin secretion and counter-regulatory hormones. There is any disturbance leads to hyper or hypoglycemia. When the counter-regulatory hormones when are talking, the glucagon oppose the insulin actions, epinephrine mobilization of the glucose stores, glucocorticoid decreases the peripheral utilization of glucose, growth hormone decreases the glucose uptake by the tissues. All prevent the hypoglycemia whenever the patient is facing the hypoglycemic level of blood glucose. Hypoglycemia responses. The reduced insulin secretion when the glucose level reaches to 80 to 85 milligram per deciliter. While the counter-regulatory hormone secretion is activated when the glucose level reaches to 65 to 70 milligram per deciliter, secretion of epinephrine is critical for the restoration of glucose level when patient faces hypoglycemic episodes. This cartoon is showing how the glucagon or epinephrine, two counter-regulatory hormones, are released to increase the glucose production via the gluconeogenesis and glycogenolysis. The glycose hypoglycemic symptoms. There are two types: neurogenic or autonomic nervous system responses, or neuroglycopenic responses. Neurogenic or ANS responses are adrenergic symptoms are patient can feel palpitations, tremors, anxiety, and pallor. Cholinergic symptoms are patient feels hunger, butterfly sensation in abdomen, paresthesias. Cholinergic and sympathetic response like sweating. Patient lots of sweating with unexplained sweating is a feature of hypoglycemia. The neuroglycopenic responses like the behavioral changes. When blood sugar reaches to below 54 milligram per deciliter, there is a behavioral changes are there. Patient irritable, complaining of headache, confusion, and fatigue is there. The prolonged hypoglycemia leads to seizure, coma, and death. Nocturnal hypoglycemia is a very common in type 1 diabetic patient on insulin therapy, also in type 2 diabetic on insulin therapy. The patient can detect the nocturnal, or doctors can detect that nocturnal hypoglycemia, and patient is complaining of morning headaches, lassitudes, night sweats. Patient complaining कि मैं रात भर सोया, मेरे सारे कपड़े गीले हो गए, बेड शीट गीली थी. That can indicate the nocturnal hypoglycemia is there in the patients. Difficulty in awakening, nightmares, डरावने सपने is also a important feature in children and adults, can causes the hypoglycemic features. Loud respiration. In our patient, husband detect the hypoglycemic episode by loud respiration. He noticed that the patient is in loud respiration during the sleeping time, or he tried to awake the patient, but she didn't respond, and patient brought to the emergency room. Hypoglycemic awareness. There is a reduced counter-regulatory hormonal response to hypoglycemia. This causes impaired gluconeogenesis and glycogenolysis and leads to hypoglycemia. Reduced physiological response to hypoglycemia that causes patient unaware of the reduced blood glucose, and patient take no action to restore normal levels. Here is the counter-regulatory response failure in hypoglycemia unawareness. Glucagon release is defective. Epinephrine becomes the primary counter-regulatory hormone, but secretion is minimal during hypoglycemic unawareness. The reduced hormonal responses. There is a decreased glucagon secretion often occur in type 1 diabetes. The prior episode of hypoglycemia reduces the threshold for epinephrine secretion. Hypoglycemia unawareness indicate that prior episodes of hypoglycemia have occurred. The risk factors for hypoglycemia unawareness are frequent hypoglycemic episodes are very common, and most important, autonomic neuropathy, use of beta blocking agents mask the sympathetic symptoms, alcohol, deep sleep, old age, especially more than 65-year age, younger children during general anesthesia, long duration of diabetic also causes the blunt the symptoms of the hypoglycemia. Type 1 diabetes are more commonly affected as compared to type 2 diabetes mellitus. Hypoglycemia risk reduction by the patient education and empowerment. There should be frequent self-monitoring of blood glucose, or try to use continuous glucose monitoring system that can sound alarm. Flexible medication regimen should be advised. Patients should be advised to blood glucose awareness training programs, test blood sugar before driving a car or operating any hazardous equipments. Patient also advised to carry glucose tablets or snacks all the times to prevent the hypoglycemic episode whenever he feels any hypoglycemic symptoms. The patient's family education is very important part in a hypoglycemic unawareness patient. The signs and symptoms of hypoglycemia should be explained to each family members or caregiver, or especially in co-workers. Teach family members to administer glucagon if patient is non-responsive. Keep the pre-filled glucagon injection or intranasal glucagon within reach to the patients. People with hypoglycemia unawareness always wear a bracelet or carry medical ID those easily identified by the medical doctors and healthcare professionals. Treatment of hypoglycemia unawareness. Patient in the stage level of 1 or 2 can be treated with oral. When patient examine blood glucose showing the asymptomatic hypoglycemia can be treated with 15 gram of glucose. There is a rule of 15. Appropriate 15 gram of glucose should be taken immediately. If it is not available, the appropriate oral replacement includes a half cup of fruit juices or biscuits, half cup of milk or crackers. After treatment, retest the blood sugar in 15 minutes. If blood sugar is less than 70 milligram per deciliter, give an additional source of carbohydrate. Patients are advised to consume regularly, but should be avoid more or more meal to prevent hyperglycemia. What should we do in the stage 2 level? If patient is awake, give the oral treatment with 20 gram of glucose tablet. If patient is unconscious, parenteral 25 gram of glucose in 50% solution to be given, or parenteral 1 milligram glucagon subcutaneous or intramuscular injection. If there is intranasal glucagon is available, 3 milligram per ml that is available in the name of the Baqsimi can be used. What precaution to be taken for these patients? Avoid tight glycemic control and low number should be avoided in these patients. Normalization of autonomic response takes at least 7 to 14 days. So it will take up to the 3 months in some patients. So should we avoid hypoglycemia episode in the next 1 or 2 months? Switch human insulin to analog insulin if there is possibility. Implementing the CGM that can sound alarm at the time of falling blood sugar levels. The take-home message for today is a variety of reasons for hypoglycemia unawareness. Warning signs symptoms do not exist that leads to severe life-threatening hypoglycemia episode, especially in hypoglycemic unawareness. Hypoglycemia unawareness negatively affect person daily lives and careers. In hypoglycemic unaware patient, raise the blood sugar level to control threshold for at least 2 weeks. Wear all the time bracelet and medical IDs by the patients. Keep all the time sugar candies, sugar jellies, glucose tablet, and glucagon within the reach to the patient. Use of CGM equipped with the alarm or frequent glucose monitoring is required. Check blood sugar prior to inject insulin to prevent hypoglycemia and by reducing the strictness of blood sugar targets and educate the patient, family members, and co-workers. Thank you very much.
Anil, it was a nice case. And we know that hypoglycemia is a
Very common in the
is
day-to-day
very
practice.
common. And it is so much disturbing that many of the patients, after developing a serious episode of the hypoglycemia, they refuse to take insulin in the future. They are so scared that they always refuse that hypoglycemia can cause death and loss of consciousness. But again, we have to be watchful and we have to inform the patient what are the timing, like hours.
है हाँ दे दो 4 बिस्कुट दे दो और सुबह दिखा देना एक गोली देना
Anyone boss? Hanji.
Sir, my message is it has been a wonderful discussion and a beautiful presentation by Dr. Anil Samaria. We all know treating a diabetes and by using an insulin is a double-edged sword which can make disastrous and which is a boon otherwise also. Number one. Number two, in such a case, there has to be a proper counseling to be done always, not even in this case, otherwise also, that hypoglycemia can make disastrous, hyperglycemia not. Number one. Number two, the dosing of prendial insulin 10-10-10 is probably seems to be not justified because always the evening time insulin should be by 7, 8 or 6 has to be done, number one. Number two, never try to mix sulfonylureas with insulin uses where you are using basal and bolus. A patient who is already having a very low C-peptide and insulin level 50 means that patient is not being managed well. She is a type 1 diabetic. So no place of OHA like a sulfonylurea, number one. Number two, hyperinsulinemia is a proper, she has been overdone with the insulin, and that has been result because it could be like an iatrogenic or could be that patient has missed her diet. Number three, patient plays a competitive sports. She is in a badminton, she is a gym, she is all playing in a competitive sports. Such
Will
a
it not
competitive
be better
sports.
to discuss all these points one by one, Dr. Pradyuman Bose?
Boss, ये तो आप कहोगे, हम तो वही बोलेंगे.
हाँ, otherwise, we all will go on listening, and by the time
नहीं,
we'll
sorry.
forget all these topics. So
ठीक
one
है,
by
ठीक
one,
है.
we discuss all these points.
नहीं,
So
मेरा तो सिंपल सा मतलब ये है, hypoglycemia can kill a patient, can have a
yes,
disastrous. Insulin is a double-edged sword, number one.
yes.
In such case, she has a very low C-peptide and hyperinsulinemia almost level is 50. This is disastrous. She has been given an insulin such a high dose, which seems to be improbable. Type 1 diabetes does not.
Dose depends on the requirement of the patient. Many of the
I
time,
agree, but
40
I'm
minutes,
not
10
denying.
kg.
I'm not
If this
denying.
patient is type 1 diabetic,
But
receive
the-
10 units 3 times a day and 20
It's
units
Yeah,
creatine.
not a
you're
very
right.
high dose,
She is
not a very high
advised
dose.
1 month prior.
Yes.
No,
She's
but
not
the
concerned
point is
with
the
any
evening
physician.
dose. No, the message is evening dose. If she's doing 10, 10, 10, third dose, evening dose should never be 10. It should be 7 or 8. That is my message. And a proper counseling should have been
Hypoglycemia
done.
developed in the evening hours, not in the night. So
No,
for
I'm not saying that way. But even whatever they're done, dosing of prandial insulin is always in evening hours on a low. Patient is being injected, and what the basals we have it. They are not absolutely a flat insulin. Basal do have a peak.
that again,
Here-
huh.
That basal do have a peak. So in the night time, giving a 10 unit prandial insulin and a basal again may precipitate hypoglycemia.
So we have to
the
take
message
care of
है.
evening and night nocturnal hypoglycemia, you say, है na?
Yeah.
Yes.
So,
Any
and
other
she's
comments?
in a
Karan, Dr. Puneet?
Yes, sir.
What it seems that basically the patient developed hypoglycemia because of badminton, playing badminton. This is an unaccustomed exercise. It was an unaccustomed exercise. So because of that, so what is the protocol whenever the patient starts playing or starts going to gym?
That is very
What
important.
should be the protocol? Because many of our patients ask that whether we can go to gym, the patients are insulin. So what should be the protocol to suggest when the patient is starting a newer exercise or going to gyms?
Always try to explain the patient to do exercise aerobics, not heavy exercises, but it should be gradually upgraded. Or blood sugar should be monitored each and every time during and after the exercise. That is very important part because after the exercise, the sugar level can drop. Or during the exercise, patient also advised to take snacks before start the exercises and after the exercises. So keep monitor regularly over the glucose. If there is a chances of hypoglycemia, like our patients, she had regular exercises, yoga, कभी तो बैडमिंटन खेल लिया है, कभी योगा कर रही है, कभी रनिंग में जा रही है. This is unusual exercises. The patient should be explained what kind of exercise should be done, and each time he or she should be monitor blood glucose level each and every time, so can prevent this kind of the situation. These are a very dreadful situation can happen sometimes. We can see in the one another patient in my ICU right now, same day, old age patients presented with hypoglycemia unawareness, but there is a cause is renal failure. Here is a young lady should be advised exercises, light exercise, aerobics, and keep watch over the blood sugar levels each and every time.
Yes,
Otherwise,
concomitant medications, and we have to see for renal failure. One symptom I want to add is frequent yawning. This is very common in patients developing hypoglycemia. Early symptom.
Just we should take care of one. Whenever the type 1 diabetic or type 2 diabetic patients, whenever the patient is going outside, ask him to just take something to eat now. Otherwise, don't go outside.
Yeah,
When
definitely.
you're planning to go for exercise or you are going outside, just take something, then after go. Patient usually go in the morning hours for the running or walking like that. So take the breakfast, or you can take the some like fruits like that. Then after you go for the walking. Or if you want to go at the evening time, then you take the snacks at the 5 p.m. Then after getting snacks, you go outside like that. Now, don't go empty stomach. Or if it is feasible, then just check the blood sugar. If your blood sugar level is okay, then you can go. If it is less than 100, then just first take the food, then after you can go. Or if it is more than 250, then you just take the manage your diabetes, then you can go. Like that we can advise the patients, because most of our patients nowadays, they're having glucometer with them. So first, whenever going outside, it is recommended that whenever you're going outside for playing games or for exercise or whatever it is, then first you check your blood glucose, then after you can go outside. So depending on the blood glucose level. So mostly type 2 diabetic patients are having their blood glucose controlled. So whenever they are going outside, ask them to take the snacks, then you can go.
The site of injection, I think the site of injection is very important in patients who are going for exercise. Supposing we are
Yes.
giving an infection thigh region or in the arm region, the type of exercise which is the going person is going to do will get the insulin absorption faster. So site of examination is also contributing a little bit in the patients who are going for exercise after taking the insulin dose.
Yeah,
Definitely.
absolutely right, sir. Site of injection usually matters. If he is doing some exercise with his upper arm, so he should not have taken the injection on the upper arm, because once the muscle activity will be more, so the absorption will be faster. So once the absorption will be faster, so blood sugar disposal will be faster. So chances of hypoglycemia will be more on that side. But actually, usually we are taking the insulin on the abdomen, so it is not going to affect. More affection is seen with the thigh. Once the people are using the injection on the thigh and they are going for the outside activity like exercise or running like that, so it affects the absorption of the insulin. So site is also important.
Dr. Surender?
First of all, thank you very much, sir. And then thank you, Dr. Anil Samaria. Everything already has been covered by you as a hypoglycemic unawareness. I just want to ask you one question regarding hypoglycemic unawareness. Is it a reversible and a irreversible? Suppose the individual, we will declare
Hypoglycemia unawareness is a reversible condition. But in the type 1 diabetes with longer duration, their glucagon response are blunt. When there is a prolonged duration of diabetes and repeated hypoglycemia, the hypoglycemic response, hyperglycemic response of glucagon is blunt in some patient, but not on the all patient. It should be, or it must be, reintroduce the hypoglycemic symptoms in each and all patient to prevent the further disasters in these patients. So we keep the blood sugar level higher to prevent the hypoglycemic episode without awareness. It is a reversible condition. Keep the blood sugar level at least 2 weeks to 1 month at the higher level. So we can go for the sensitization of all the receptor activation of the epinephrine and glucagon receptor to be activate whenever they feel the patient is going blood sugar level lower side. So these are the necessary to activate all these symptoms to prevent the further disasters.
Dr.
Sir,
Anil.
yes, Surender.
Dr. Anil, as per concern about the reversibility, the neuropathy which is usually developed with the diabetes is the 50% are the reversible and the 50% are the irreversible. So we cannot be expect that every patient will be the reversible. In this
Not each
situation,
and every patient.
are at 50%. And suppose the individual who, in spite of the decreasing dose of the insulin or management of the insulin as well as the removing of the drugs particularly responsible for the hypoglycemia, unawareness, उसके बावजूद भी अगर उसको होता है तो फिर क्या करना चाहिए अपने को?
When we have to prevent, all the precautions should be given or instructed to the patient. Patient is affordable. The best therapy is to do the CGM with alarm. That is the best remedy. Whenever there is an alarm in the CGM, patient is aware there's blood glucose level is falling. Check the blood glucose level. and start consuming the snacks or whatever available at the nearby. If patient is in frequent hypoglycemic unawareness episode like our patients, family members should be alert regarding signs and symptoms of hypoglycemia and ready glucagon, especially the subcutaneous or IM injections or intranasal glucagon should be in at bedside of the patient or whenever in the possibility of the keep the in the bags or whenever the easily reachable areas should be there. There is a glucagon injection. So whenever patients attendant find that there is a hypoglycemia episodes, inject the glucagon or intranasal glucagon to be given at the same time. After 10 to 15 minutes, patient will be recovered at the home. But it should be advised to attendants to please bring the patient as soon as possible to the hospital to recover the hypoglycemia as soon as possible to prevent the neuroglycopenic episodes.
So the Surender, there are two things. One is hypoglycemia. Hypoglycemia can occur in any of the diabetic with the insulin secretagogues or insulins, or improper dosing, improper meal planning, prolonged distance in between two meals. Another thing is hypoglycemia unawareness, and that is patient is not able to perceive or feel the prior sensations which are because of the autonomic nervous system, and they usually develop because of so many factors. One is the neuropathies, other is those patients who are under the strict control of the diabetes. These patients also develop hypoglycemia unawareness. As you were asking, Dr. Surendra, this kind of the hypoglycemia unawareness is reversible. This is a phenomena in which patient is not perceiving the hypoglycemia in spite of the low sugars. And because of the loss of sympathetic symptoms, this hypoglycemia unawareness develops. This is different and this is reversible. As you told that in around 50% of the patients, it gets reversed. And hypoglycemia is different. The hypoglycemia and awareness, they are the two different entities. So you are right, Surender, that it is recoverable and around 50% of the patients may recover from this hypoglycemia unawareness.
So today I come across one article, azathiophylline. The individual who is not responding in spite of decreasing dose of insulin and the sulfonylurea. The one literature suggests you of the using of the theophylline are the useful and an irreversible type of the hypoglycemic unawareness.
Okay, that's good.
Is there any, Dr. Samaria, will you give the comment regarding this thing?
Regarding
Theophylline.
theophylline, I didn't read any article regarding the theophylline recovery of this hypoglycemic unawareness in any book. Any article, please share your experience with this.
Definitely today I will
Few
share the same
drugs
article.
have been used for the treatment of hypoglycemia unawareness, and few reports about theophylline and clonidine have also been tried to get relief from this hypoglycemia unawareness.
Some hypoglycemia can be reverted with dihydroxide and
Hypoglycemia is different, yes. Hypoglycemia is reversible with, as you told, that glucose, then injectable glucose and glucagon. And hypoglycemia unawareness, we can use certain drugs, but with time, it gets reversed in around 50% of the patients.
Thank you,
So
Dr.
as far as,
Very nice presentation.
Yeah,
And-
theophylline trials, as far as trials are concerned, it was tried, but actually it is not recommended for the
Not
treatment
recommended.
of hypoglycemic unawareness. So we are not using theophylline for the hypoglycemic unawareness. So better we have the other things like the patient is having the hypoglycemic unawareness. So just keep the blood glucose level on the upper side for the next 2 to 3 weeks, as described by Dr. Anil Samaria. That will be sufficient for the patient to regain some hypoglycemic awareness. And other thing is that we should avoid the many episodes of hypoglycemia in such kind of the patients. So we know in type 1 diabetic patient, particularly where the glucagon, this defense mechanism, insulin defense mechanism is lost because the injection is having more insulin. They are having exogenous insulin is more in those patients. So there's nothing like that. The insulin level will be decreased from the pancreas. So that is lost. Second thing is that the glucagon defense. So once the insulin level is higher at that time, so the glucagon level will already be higher on that side of the patients. So higher more secretion of the glucagon level will not occur in such kind of the patients. So second defense is lost. Third thing, the main thing is that the this epinephrine hormones. So that defense is also lost in those type 1 diabetic patients where the insulin level is not there. There's no endogenous insulin level is there. Same thing happened with the in the type 2 diabetic patients. They are having prolonged type 2 diabetic patients who are having who have lost the beta cell function in those kind of patients. So in these patients, the thing is that only we should keep the blood glucose level on the upper level for the next 2 to 3 weeks. So that is suffice for those to gain some awareness. And also the particular medicines like beta blockers, we should avoid in such kind of the patients. So that would be sufficient for this kind of the patients.
Very good. Very right. We have to watchful for certain group of the patients who are prone for development of the hypoglycemia, and particularly if they have hypoglycemia unawareness, we have to fix targets at a much higher level. What we recommend in the younger and patients who are neurodiabetic. So in those in susceptible patients, we have to keep targets at much higher level. So, Dr. Punit, will you like to say in which patients would you like to have targets at higher level to avoid hypoglycemia?
I think this is the right mechanism. We should keep the blood sugar levels higher side for a few weeks so as to regain the unawareness part of hypoglycemia. And secondly, the concomitant drugs, beta blockers, have to be stopped because it's very important to counsel the patient and to see the concomitant medication. We usually fail to see all the medicines which patient is taking along with the insulin and all. So continuous monitoring is another thing which should be done in these patients.
So the very elderly patients with the renal failure, patients who have other neuropathic symptoms, or they are alone, they have poor access to the lungs. In these patients, we should avoid tight control of the diabetes. Otherwise, on all the patients of the diabetes, the gap between the lunch and dinner is quite larger as compared to between breakfast and lunch, which is usually 4 hours, and the gap between lunch and dinner is around 6 to 7 or 8 hours. And all these patients, if they are working in the office or in the shops, by the time of the 7 or 8 or pre-dinner, the sugar goes up to 70 or 60 or 80s. And sometimes if they work for a larger period or for the strenuous work, they usually develop hypo at that time. So in these all patients, we should recommend a good snacks along with the evening tea around 5 p.m. so they do not develop these symptoms of little hypoglycemia or mild hypoglycemia in the pre-dinner period. So that can help in these patients.
So midnight monitoring, early morning monitoring, 4 p.m. is also suggested.
Yes,
I mean, intermittent monitoring of these.
Yes. Those who have good tight control, we should always keep watch on that. Particularly if a patient gets up in the morning and gives a complaint of that he is having headache. So that may be because of the mild hypoglycemia which he was experiencing, and in the morning he gets up with the headache. So all these precautions we have to keep for the patients. Dr. Pradyuman boss, anything?
बॉस मेरा तो ये कहना है कि कुछ लोग दे आर ससेप्टेबल फॉर हाइपोग्लाइसीमिया नंबर 1 और हाइपोग्लाइसीमिया में क्या है इट्स अ कंट्रीब्यूटिंग फैक्टर बाय द फिजिशियन पेशेंट हिमसेल्फ एंड मेनी टाइम्स दे आर ओवरलुक्ड एक जो मैसेज यहाँ शुरू में दिया कि उसको बैडमिंटन नहीं खेले या उसको जिम नहीं जाना चाहिए या उसे एक्सरसाइज नहीं करनी चाहिए दिस इज समथिंग
खेलना चाहिए पर
ग्रेजुअल और एक मिनट मेरा मतलब ये है एक मिनट अरे नहीं दूसरा हाँ अरे मैं वही कह रहा हूँ दूसरा वही क्या है कि पहले उसको शुगर चेक करो बाद में शुगर चेक करो प्रैक्टिकली दिस इज नॉट पॉसिबल नंबर 1 नहीं एक मिनट लेट मी फिनिश बेसिक मैसेज हर एक को कहना चाहिए कि हैवी मील्स ना हो मिड टाइम बीच में स्नैकिंग शुड बी डन, और जब भी वॉक पे जाएं, गेम्स के लिए जाएं, दे शुड ऑलवेज हैव सम स्नैक्स, उसके बाद में मॉर्निंग वॉक भी करें, बिकॉज मेनी टाइम्स व्हाट हैपेंस, दे आर हाईली सेंसिटाइज हो जाते हैं, दे कैन गो हाइपोग्लाइसीमिया बाय वॉकिंग, बाय एक्सरसाइज। तो कुछ लेकर के जाएं, वॉकिंग पे जाएं, एक्सरसाइज करें। कॉम्पिटिटिव स्पोर्ट्स को थोड़ा सा इनको अवॉइड करना चाहिए। कॉम्पिटिटिव स्पोर्ट्स इज ऑलवेज लिटिल इंजूरियस, सबसे बड़ी बात होती है। लेकिन दे कैन डू रनिंग, दे कैन डू जॉगिंग, दे कैन डू स्विमिंग, बट ऑलवेज वॉचफुल रहे। और डाइट का बेसिकली इट्स ए लाइफस्टाइल। कई बार क्या होता है, हमने इंसुलिन ले लिया, हमने खाना नहीं खाया, ये मेरा कहने का मतलब ये है। एंड उनका फूड क्या है, बिकॉज द पॉइंट इज दिस, अगर उनका फूड इज डिफेक्टिव, अमाउंट ऑफ फूड ज्यादा है, फूड में उनका मिलेट्स नहीं है, दे आर मोर वीट बेस्ड फूड, तो उनको ये समझाना चाहिए कि वीट को आप कम से कम करो और अवॉइड करो। मल्टीग्रेन आटा करते हो तो व्हाट हैपेंस कि दे विल नॉट गेन हाइपो एंड हाइपर। ग्लाइसेमिक वेरिएबिलिटी का सबसे बड़े जो कारण है इज द नंबर वन फूड। अगर हम मेडिसिन को छोड़ दें तो प्राइमरली द फूड इज वेरी इंपॉर्टेंट। आप वही 2 चपाती गेहूं की खाओ और वही 2 चपाती अगर बाजरे की खाओ, ज्वार की खाओ, रागी की खाओ, तो थिंग्स आर डिफरेंट। नंबर वन, व्हीट में होता क्या है, इनिशियली देयर इज अ किक एंड इट फॉल्स फास्ट, while
Yes,
in
sir.
millets it's a very slow rise, lasts pretty long. So the meal diet plan is a more important, and the same day how to live it is more important. कहने का मकसद है ऐसा ना हो कि आदमी इंसुलिन को छोड़ दे हाइपोग्लाइसीमिया चक्कर डर से।
Yes,
सो
you have
प्रॉपर
to
काउंसलिंग उसको
right,
शुरू
sir.
में समझा देनी
You
चाहिए।
have to take,
That
yes,
is the message.
right, proper counseling is must, sir.
सर
तो
एक्सरसाइजेस
अनिल
अवॉइड
समरिया का
करने के लिए नहीं
प्रेजेंटेशन
बोला गया
जबरदस्त।
So
है।
we should give option.
एक्सरसाइज अवॉइड करने के लिए नहीं बोला गया है, जिनको हाइपोग्लाइसेमिया
नहीं,
अनबैलेंस्ड
ये कहा गया है
ट्रीटमेंट
कि
है,
एक्सरसाइज से
it should
पहले
be
शुगर करे,
alert
एक्सरसाइज के बाद में शुगर करे, वो
only
नहीं
for
होना
that
चाहिए।
patient that's having the
Sir,
recurrent
just
episode
Those who have
hypoglycemia,
hypoglycemia
not
unawareness,
for the each and
in
every
those
patient,
patients, yes, in those
not
patients,
हाँ
each and
नहीं,
every patient.
sir, जहाँ
नहीं
पर
हम
by
तो
the way
आपकी
वो
तारीफ कर रहे हैं अनिल जी। अरे
जी
हम तो अनिल जी आपकी तारीफ कर रहे हैं, आपने बहुत अच्छा
अरे
प्रेजेंट किया। गलती
face तो बहुत ही
आपने
बढ़िया किया।
अवेयरनेस किया, बहुत बढ़िया,
Shailesh,
बहुत बढ़िया।
Shailesh, would you
नहीं
like
नहीं,
to say something? Dr. Shailesh?
रिद्धुमन जी बहुत अच्छे वक्ता हैं और
हाँ,
अनिल जी ने भी बहुत अच्छा बोला। मैं केवल ये ऐड करना चाहूंगा कि मेटफॉर्मिन से भी हाइपोग्लाइसीमिया, जो कि बुक लिखते हैं, बहुत रेयर है। मैं अपना तजुर्बा बताऊंगा, 2 बार मैं हाइपोग्लाइसीमिया हो गया मेटफॉर्मिन। 5-6 साल पहले मैंने प्रकाश जी से पूछा, भाई प्री डायबिटिक की श्रेणी में आ रहे हैं, तो उन्होंने कहा बॉस मेटफॉर्मिन शुरू कर दो 500 मिलीग्राम। मैंने शुरू कर दिया। अब एक दिन हमारी सीएमई के टॉक में, अब मैं सोचा आज तो खाना होगा, 1 ग्राम लगा के जाओ आज तो मेटफॉर्मिन की, और वहाँ खाना सर्व ही नहीं फैमिली। तो बैठे बैठे पसीना आने लग गया, चक्कर आने लग गए और गिर गया। लोगों ने कहा एमआई हो गया, आईसीयू ले जाओ, आईसीयू ले जाओ। डॉक्टर गहलोत साहब मेरे सीनियर, उन्होंने कहा मैं तो कई बार इस तरह हाइपो में गया हुआ हूँ, इनको शक्कर खिलाओ, मिठाई खिलाओ, शक्कर खिलाओ, तुरंत खिलाई और आ जाए। दूसरा ये हुआ कि सुबह सुबह खेलने चले गया, संडे का दिन, प्रताप नगर जयपुर, वहाँ खिलाड़ियों के भी हाइपोग्लाइसीमिया हो गया। तो ये मेटफॉर्मिन को भी आप इस तरह मत लो कि मेटफॉर्मिन से कुछ नहीं होता है, उसका भी अपने को ध्यान रखना पड़ेगा, विशेष करके जो प्री डायबिटिक्स।
yes, sir. So we have to keep caution, to have caution with the metformin also,
और
along with
सस्टेंड
other
रिलीज
drugs.
का जहां तक सवाल है, तो ये
मैं आपको बताऊं मेरा तजुर्बा,
है, तो इसका मतलब
देखो प्रकाश जी,
हाँ, हाँ।
अगर ये बात है, मैं आपको बताऊं, मैंने 5 साल पहले सीजीएम लगवाया। आई एम नॉट अ डायबिटिक, लेकिन मेरे को
हाँ।
क्या होता, 10-11 बजे मेरे को है ना एकदम वीकनेस आती, सुस्ती आने लगती थी। तो मैंने कहा यार सीजीएम अपन लगा लेते हैं। तो मेरी 10-11 बजे शुगर जो है 54 के आसपास आ जाती थी, फिर वो
हाँ,
धीरे 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 होती। तो कहने का मतलब ये नहीं है कि हाइपोग्लाइसीमिया डायबिटिक्स में ही होता है,
नहीं
इट
नहीं
इज अ
सर, सबको
फिजियोलॉजिकल
होता है।
ऑल्सो, बट सबको होता है, ये बिल्कुल सही
आप किस
बात है। तो
टाइम पे
मेटफॉर्मिन तो उसको
कितना खा
प्रोटेक्शन
रहे हैं,
करते हैं।
कितना वर्क कर रहे हैं, इंडिविजुअल की
यस,
ससेप्टेबिलिटी है, बहुत सारे फैक्टर्स है सर। फिर आपका
बहुत सारे फैक्टर्स
कार्डियो
हैं।
कितना है, सिंपैथेटिक नर्वस सिस्टम कितना एक्टिव है, there are
Yes,
so many things, there are so many things, sir. Dr.
तो
Shailesh,
but it is a beautiful presentation.
प्रकाश जी खुद ही
Yes,
चिक्की
sir.
लाई खाते हैं रात को 1 बजे, रात को उठ के लाई खाते हैं, सिंधी लाई चिक्की खाते हैं या मिठाई खाते हैं रात को 1 बजे, इन्होंने एक दिन मेरे को बताया।
भाई देखो, हमारा तो मैसेज है कि आप खाना 7-8 बजे खा लो और रात को 10 बजे 2 बिस्कुट, थोड़ा दूध या कुछ लेकर के सो। यू शुड नॉट ईट, मतलब यू शुड नॉट कि डिनर के बाद आपने भूखे पेट सो गए। Always patient supplement a little small snack, which is what you call as a supper,
Particularly
around
if
10
you are
o'clock.
awake up to
Especially at
10:30 or 11. If there is a
yeah,
gap of
10 to
3
11
hours,
should be a glass full of milk without sugar or some snacks
Whatever it is, it
or
can be an
fruits.
apple. It can be an apple also. It can be
Yeah, yeah.
अनार, कुछ भी खा लो। और दूसरा मैं तो ये कहता हूँ बेसल इंसुलिन सुबह लगानी चाहिए। मेरा मैसेज तो ये, क्योंकि दीज अगर नॉर्मल बेसल आपका जो भी बेसल अगर आपका आता है, दे ऑलवेज have a little peak. Not talking about degludec, but all basils have a peak. तो उसका जो पीक को अवॉइड करने के लिए आप मॉर्निंग आवर्स में लगाओ, क्योंकि डिनर में कई बार आप लगा सकते हो और हो सकता है 30 दिन में आप 3-4 दिन भूल जाते हो। तो ऑलवेज गिव अ ब्रेकफास्ट टाइम।
right, sir, right, but the problem is that the peak is not very large. Another thing is in early morning.
I agree.
the rise of-
I'm not saying so.
Another thing is in the early morning there is a rise of so many other hormones which causes increase of the blood sugar level, what is called as down phenomena. And if we give morning 9 a.m. with glargine, the effect of that hormone or that injection will not persist to the next day morning up to 4 or 5 or 6 a.m. So that is the advantage if we give injection during the night hours around 8, 9 or 10 a.m.
लेकिन मैंने रिसेंटली ये देखा है बहुत एंडोज ने मॉर्निंग आवर्स में लिखने लग गए।
Yes, we
काफी
give,
चेंज आ गया पहले से।
particularly in certain patients who are developing hypo and
दूसरा क्या है कि ब्रेकफास्ट, आदमी ब्रेकफास्ट तो लेगा ही भाई, घर पे तो सोएगा और सुबह उठ के ब्रेकफास्ट लेगा ही। तो वो मॉर्निंग आवर इज अ वेरी कंसिस्टेंट व्हाइल डिनर्स कैन बी समटाइम्स आपने लिया नहीं लिया, आप लेट नाइट हो गए, आप शादी में चले गए, पार्टी चले, बहुत सारी चीजें होती हैं।
patients who have tendency to have low blood sugar in the early morning hours, it is better to give glargine in the morning hours around 9 a.m. But otherwise, night time is equally good and has added advantage of counteracting the other hormones like sympathetic hormones or cortisol or growth hormone, which are increased during morning hours. So, anyone else? Dr. G D
बहुत
Ramchandani.
बढ़िया प्रेजेंटेशन अनिल जी का, स्पेशली एचयू के बारे में डिटेल किया, बहुत ही बढ़िया लगा। अनिल जी बहुत बहुत बधाई के पात्र हैं।
अनिल जी ने बहुत ही बढ़िया बताया और प्रैक्टिकल यूज का टॉपिक था आज।
Thank you.
जी डी रामचंदानी, आर यू ऑनलाइन?
हमेशा ही प्रैक्टिकल वाले होते हैं।
With the thanks to the Dr. Anil Samaria for a nice selection of a good case, which is a very much used and nice presentation. And of course, all the three panelists, Dr. Punit Rijhwani, Dr. Surender Kumar, Dr. Sanjay Saran, who made it interesting and interesting also. Dr. Pradyuman Sharma, Dr. Gwalani, and all those who participated. Thanks to all of you. So we will again meet.
Thank you. And thanks to congratulations on the captain.
Yes, panelists.
Captain को congratulations. जबरदस्त केस कर दिया आपने.
Congrats to
Thank you, sir.
Thank you. Bye bye. Thank you.
Bye bye.
Good night.
Thank you.